delighted, Friday Chalk Talk members, to present Rod McLeod. Dr. McLeod is from New Zealand, which we're excited about. He retired from clinical practice in 2019. He was a practicing physician for 45 years, which is absolutely incredible. Worked as a palliative specialist for about 30 years in both, well, all of England, New Zealand, and Australia. Some really cool and impressive appointments. 2003. Some of these aren't going to sound familiar to us, but they sound impressive to me, I guess is the way I'll put it. But the inaugural South Health Professor in Palliative Care at the University of Otago. And is it Dunedin? Is that how you say it?
Dunedin.
Dunedin, sorry, Dunedin School of Medicine. In 2013, appointed as a conjoint professor in palliative care at the University of Sydney. He has an honorary position at the University of Auckland, and he's working with the Violet Initiative in Australia, which I think is really interesting. We talked briefly about it, and it's a Australian organization to support and facilitate end of life planning for the public, which is kind of similar, I think, to like our Death Over Dinner kind of organization. So it's really a cool thing, and he's been really involved with that. Just a gob ton of publications, book chapters, just impressive numbers. Most recently, he's the co-editor in chief of the textbook of palliative care, which is published by Springer. There's a revised and updated edition coming out very soon. We were just discussing that he was appointed a member of the New Zealand Order of Merit in the Queen's Birthdays Honors in 2015. The fun facts, 6 grandchildren and a small dog that keep him active. And also he's learning archery, which I think is a really cool, a really cool post-career skill to learn. We are going to be discussing the article that he wrote about uncertainty. And the title is Certainty is an Illusion, Lessons for Palliative Care. And I think it's a really great article. And so I'm going to let him talk about it, and then we'll have time for questions at the end.
Thank you. Thank you so much. It's an honor and a privilege to be invited to speak with you today. And thank you particularly to Martin and Leanne for the invitation. So my friend and colleague Rosalie Shaw wrote in the introduction to her excellent book, Soft Sift in an Hourglass, Stories of Hope and Resilience at the End of Life. Caring for the dying is often very demanding. It requires not just clinical competence and the ability to communicate with honesty and compassion. It also demands that we're able to live with uncertainty and the awareness that death comes to us all. So it's aspects of that uncertainty in the world of palliative care that I'll briefly discuss now. When I moved to New Zealand from Britain in 1994, I was given the opportunity to teach medical students at the University of Otago, Wellington School of Medicine. I knew that inadequate management of uncertainty by clinicians might cause unnecessary concern and distress to patients. I'd previously had the opportunity in England to speak with the medical sociologists David Field and Tony Walter, who helped me understand that part of the medical socialization processes and themes for medical students that had attracted most attention were the attitude learning sequences of training for certainty, training for detached concern, and training in the management of medical mistakes and failure. I wrote at the time that these sequences have been challenged by the suggestion that certainty and uncertainty should be seen as two separate phenomenological issues, which may coexist simultaneously, reflecting in their own ways different practical and theoretical interests. Disease and ill health are culturally defined and cannot necessarily be seen in concrete terms. The human being who suffers ill health is not completely knowable. Therefore, elements of the science of medicine remain uncertain. The consequence of this is that the elements of ill health that can, to a degree, be controlled more readily become the focus of constant improvement or learning. As a society, we've been encouraged to believe in the most scientific aspects of medicine, and this is encouraged in the process of socialization of medical students. By the time they start practicing medicine, most doctors have had 2 decades of learning. As medical students, these doctors often started with a dead body and quickly were taught everything that was similar in each human being, and that process continues through their education. As they progress, their compassion and understanding of what makes people different declines. Students increase their ability to act independently, but decrease in benevolence during the beginning years of medical training. Early idealism is replaced by pragmatism and utilitarianism. Shifts in interpersonal values begin before the first day of medical school. Socialization begins prior to the start of formal training. Students encounter a vast field of knowledge and soon discover that they cannot master it all. They are socialized into uncertainty. Uncertainty and death are the only certainties. These uncertainties can be divided into three broad areas. Firstly, an uncertainty that accompanies their incomplete knowledge and the ever-increasing burden of information that modern medicine accumulates. Secondly, they realize the uncertainty that flows from the gaps, deficiencies, and ambiguities that accompany that information. The third uncertainty relates to coming to terms with the dilemma of whether these gaps are there because of their own personal ignorance, or rather the imperfect or deficient aspects of scientific knowledge that medicine espouses. As learners, they often don't know what they don't know, but they also don't know what medicine doesn't know. So often they see their teachers and role models behave in a way that suggests to them that those people do know, and this compounds their uncertainty. In writing about ambiguity and uncertainty in the journal Academic Medicine, Vera Luther and Sonia Crandall suggest that this ambiguity and uncertainty deserves special attention in medical education because it can cause significant anxiety, frustration, disillusionment, self-doubt, feelings of inadequacy, that means not being good enough, and insecurity regarding their professional skill levels. It's a bit like when you get to be appointed as a professor. They write that although students may learn some strategies for dealing with uncertainty in medicine as part of the hidden curriculum, by observing their role models, there is a paucity of published literature that describes dedicated curricular initiatives to directly address ambiguity and the reaction that it causes. What we in palliative care can do, therefore, is to celebrate the uncertainty that we face in medicine. Caroline Welbury commends the value of uncertainty in her 2010 Art of Medicine essay in The Lancet. To her, the onion skin of uncertainty is liberating rather than constraining. She argues that uncertainty should be embraced because of the opportunity it provides doctors and patients to engage on more profound levels and reflect on alternative possibilities. So William Osler, who's a medical hero of mine, wrote, "Medicine is a science of uncertainty and an art of probability. Tolerance of uncertainty is a necessary skill for effective care and self-preservation. As a doctor, it can also enhance experiential learning. But why, in a world of increasing medical knowledge, capabilities, and expectations, is the extent of uncertainty rarely discussed? Evidence-based medicine provides several ways to quantify and communicate uncertainty, but does so from a probabilistic rather than a human perspective. Welbury explores the human dimension and invites practitioners to use ambiguity about medical elements as a stimulus to gain greater certainty about other facets of a patient. The implication is that more appropriate care is delivered because of improved holistic understanding. Returning more directly to normalizing uncertainty, Alexander Smith and his colleagues suggest in their essay, Uncertainty, the Other Side of Prognosis, in the New England Journal of Medicine, that in many respects, the primary communication task of clinicians is the management of uncertainty. And perhaps nowhere is this clearer than in communication about prognosis. By normalizing uncertainty and attending to the affective response to living in the face of an uncertain future, we may help our patients and their families enjoy the time they have now. The first task for us then is to normalize the uncertainty of prognosis. The second task is to address patients' and surrogates' emotions about uncertainty, acknowledging how difficult it may be for them not to know. The third task is to help patients and families manage the effect of uncertainty on their ability to live in the here and now. The search for certainty may impede the ability of patients and family caregivers to live in the present. They may believe that if they only knew what the future would bring, their decision-making would be easier. They wouldn't make mistakes or have to worry about regret. Luther and Crandall suggest that as physicians, we must tolerate some degree of uncertainty and ambiguity. These are ubiquitous elements of medical practice. But as I've already suggested, the culture of medicine has little tolerance for ambiguity and uncertainty. Patients and physicians alike are relatively intolerant of physician uncertainty. We, as a society, expect that after a thorough subjective and objective assessment of the patient, a physician will be able to make an accurate diagnosis. The inability to make an accurate diagnosis after a thorough evaluation will often lead to frustration on both the part of the patient and the physician. On one hand, the anxiety and frustration that even experienced physicians encounter when facing ambiguity and uncertainty may be constructive because it motivates physicians to continue to evaluate, ponder, and care for patients, even when a diagnosis or positive outcome is not readily apparent. However, physicians who are relatively intolerant of ambiguity are more likely to experience a greater degree of frustration and anxiety, which may ultimately lead to disillusionment and even burnout. Furthermore, a physician's tolerance of uncertainty influences his or her clinical practice. Physicians who are less tolerant of uncertainty on encountering ambiguous or complex clinical scenarios are more likely to order excessive diagnostic testing and additional empiric treatment regimens compared with physicians who are more tolerant of uncertainty. Arabella Simpkin and Richard Schwartzstein, in their article Tolerating Uncertainty, the Next Medical Revolution, write, "Our quest for certainty is central to human psychology, and it both guides and misguides us. Although physicians are rationally aware when uncertainty exists, the culture of medicine reveals a deep-rooted unwillingness to acknowledge and embrace it. Embodied in our teaching, our case-based learning curricula, and our research is the notion that we must unify a constellation of signs, symptoms, and test results into a solution. We demand a differential diagnosis after being presented with few facts and exhort our trainees to put your money down on a solution to the problem at hand, despite the powerful effect of cognitive biases under these conditions. Too often we focus on transforming a patient's sometimes murky narrative into a black and white diagnosis that can be neatly categorized and labeled. What we know now is that as we move further into the 21st century, technology will perform many of the routine tasks of medicine for which algorithms can be developed. Our value as physicians will remain in that murky space that we in palliative care are perhaps more used to occupying. All of the people we care for are living with uncertainty. We should never forget that. We have to acknowledge to ourselves and to those who we teach that we are comfortable, indeed, that we thrive in these areas of uncertainty. We must model for our students that it's okay to be uncertain. Donald Chern, in his book Educating the Reflective Practitioner, describes professional practice as high, hard ground overlooking a swamp. For palliative medicine, the high, hard ground is the scientific zone, which is fact-based, predictable, and consists of solvable problems, whereas the artistic or indeterminate murky zone is characterized by uniqueness, conflict, and ambiguity. In palliative medicine, we often practice in the artistic zone, and medical education curricula should acknowledge that some degree of anxiety is natural and predictable when operating in the artistic zone. We should strive to equip students with knowledge on how to act wisely in states of ambiguity and uncertainty. Having held professorial appointments in 2 countries, I know just how hard it is to change the way that medical education priorities are identified. In conclusion, then, as specialists in palliative care, we must teach our students that living with uncertainty is part of the job. We can nurture this by encouraging reflective writing. Students can write about feelings of inadequacy or insecurity in the knowledge that there is help if they want or need it. We can develop small group discussions so that students can voice their fears and uncertainties in a safe place without judgment or criticism. We can help develop their communication skills to enable them to understand that it's okay to say, I don't know. We can help them understand that we make decisions often based on imperfect data and limited knowledge, and to understand that in order to survive, we need to be able to live with uncertainty. After all, as Sir William Osler wrote, medicine is a science of uncertainty and an art of probability. Ironically, only certainty is a sure thing. Certainty is an illusion. So,
Thank you
that's
so
all.
much. I'm going to give the group a chance here to see if anybody wants to put out their hand. Otherwise, I know Marty has some questions, but I love your thoughts about, what changes for students as their training progresses. And it struck me when I was reading this, though, that I think that many of those comments about how we learn and how we approach uncertainty apply really to all of us. And I think I know, at least for me, I continue to have to remind myself about the things that I don't know and the things that medicine doesn't know. Those areas I think stay clear throughout our careers, although I think we get a little bit better. I hope we get better at identifying them, but it feels to me like that's an ongoing thing, not just something for medical students. Um, so this was a great talk. Marty, why don't you go ahead? I have some questions too, but I'll let you go since I don't see any other hands up right now.
Yes. All right. Thank you. So Rod, part of your paper reminded me of how a mentor of mine likes to conceptualize the whole field of medicine like it is its own religion, right? Something that has its own values, its own beliefs, its own biases, its own preferences about what end of life should or maybe shouldn't look like. Similar to like the medical socialization that you referenced in your paper. And I think as we enter into this field of medicine, we drink the Kool-Aid, and the farther we go, the deeper we get into this stuff. And sometimes we get caught into there are right and wrong answers to some of life's toughest questions. Like in particular, how should people die? All right.
Right.
Instead of approaching it from like the perspective of curiosity or uncertainty, like your topic. And I was hoping you might be able to talk a little bit about your own personal professional journey and working with or maybe against the grain of this medical socialization in palliative care.
Well, yeah, it's interesting. I want to go right back to the beginning of my career in palliative medicine. That was in the 1980s. So I went and visited a whole lot of community-based hospices in the south of England and learned that there was a different way. And in learning that, I learned that those people that were mentoring me were happy with uncertainty. They were happy with not knowing exactly what was going to happen. And they were happy with that because they knew the people better. They knew what made them tick. They had that very broad uh, view of symptoms, of physical, psychological, social, spiritual, existential, all of those things. And so they taught me that here was a different way to practice medicine. It wasn't just um, you make the diagnosis and then you follow these lines. It can meander. And what I used to tell the people that I cared for was, there's a whole, it's like you're the conductor of an orchestra. And the orchestra is all the people around, all the physicians and the nurses and the physios and the OTs and the social workers and the chaplains and the other medical specialists. And I would say to the patient, you have to hold the baton. So you're the conductor of this whole orchestra. So you say when the physician comes in, you say when the nurse comes in. If you're too weak or unwell, don't let one of the physicians take hold of the baton. Give it to somebody in your family, and they will conduct the orchestra for you because they know you best of all. Um, and that resonated with a lot of people that I cared for. I even had one guy who made his own baton so that he could sit in his bed and conduct his orchestra. So does that answer your question? It's a bit random.
No, I appreciate it. It just brought up even more questions for me. I mean, so that was an early life lesson, right? Something you appreciated back in the 80s that you started to work on. How
Yeah,
about can so you have this whole career and life of experience, decades of palliative care experience, and decades of healthcare experience.
yeah.
Could you offer us some enlightenment about maybe what were some of the lessons that took you the longest to appreciate, ones that you finally got a hold of at the end of your career, something we can aspire to work towards?
That's a really that's a really tricky question because in many ways there are so many things that I never quite got the measure of. I think what I learned, I was quite a disciple of Donald Chern, and I learned that reflecting in on and about practice was a really important thing to do. And so when I was in Sydney, I worked in a big uh, teaching hospital, and we often had trainees. And um, after every clinical encounter, I would be thinking all of the time about, what would this person want? What would I want? What would this person want? What would the family want? And how do we meld those things together? So that was while I was in the room with the patient. And then what I would do after we'd had some discussion and made some decisions, I would come out of the room and talk with the trainees and ask them what they saw, what they thought, what their plan would have been. So immediately reflecting, it doesn't necessarily take very long. It might only take a minute or two. And it doesn't, I mean, your ward round doesn't get that much longer because of doing that. And then at the end of the day, I would reflect from afar and think about the things that had gone well and think about the things that maybe hadn't gone so well. But I think having those reflections in the corridor were one of the most successful things that I started doing. And I know that the trainees, when they become specialists themselves, they would carry on doing that. And so incorporating reflection in, on, and about practice into everything that I did was something which I found really valuable. I have to say that early in my career, that reflection didn't serve me particularly well because I've Scottish heritage. I was brought up a Presbyterian, and Presbyterians often beat themselves up for not being good enough, I think. And that was one of the things that I learned. And what I used to do at the end of the day was to reflect on the things that hadn't gone well. And I found myself going into a downward spiral. And I did actually develop a major depressive disorder. Um, and so that was when I realized that my reflection wasn't necessarily going the best way that it could. But after I recovered from that, I decided to change the reflections to think about the things that went well and to applaud myself when things I could nod to myself and say, yeah, Rod, you did okay there. So that was another important lesson in the way that I practiced medicine. Because after all, we tell ourselves we're scientists, we tell ourselves we're symptomatologists, but above everything, we're human beings. And our job is to meet people on a human level. And so early in my career, I used to have this sort of carapace of protection. I even went so far as to imagine when I went into the hospice I was working at, I would imagine putting this cloak on as a bit of a protection. But I realized that that didn't allow me to get close enough to the people that I was caring for. So very quickly, I learned to take the carapace off and meet them at a human level. Yes, you can still be a scientist, you can still be a symptomatologist, but what they know when you're meeting them at a human level, and that's what they value. Yes, if I had a heart attack now, I would want somebody who knew all about the mechanics of the heart and knew which pills to give me and all that sort of thing. But very quickly after that, I would want somebody who cared about me as a human being and understood me as a human being. And I think what medicine sometimes misses is the fact that it is essentially the meetings of two spirits, two souls who come together and share a decision and move forward from there. So I guess one of the things that I learned was to be confident in myself as a human being. I mean that takes a lot of time and effort.
Thank you for all of those great lessons. We are at time. I just want to acknowledge that, but I do have one more question, and this has just been so interesting. So I'm going to ask it, but I'm just going to give everybody a pass if people do need to drop off because I know we're at time. And Rod, if you need to go, we can we can wrap
Yeah,
up
no,
too.
no.
But I guess one thing that struck me both in listening to you talk about things you've learned in your career, but also from the article itself, um, I think it's normalizing the uncertainty is really important. But I feel like where we struggle, and Marty, you kind of struck me also with the idea of this sort of like almost a religious perspective, because sometimes I feel like we're almost being heretical when some of our colleagues are claiming certainty that doesn't exist and sort of
Yeah.
proselytizing that to the patients. And then when we're coming in with a different message that's not as certain, and again, not that we're necessarily contradicting our colleagues, but it's, I guess that's my question is how do you normalize it when we have so many colleagues that are, pressing so hard to portray certainty that is false? And have you any tips for that?
Well, it's a real challenge. One thing that can help is if you're a professor, and people listen to professors more than they listen to people who aren't professors. I think what you have to do is establish yourself as somebody who uh, can be relied on to be honest and sincere uh, all of the time.
Mm.
And once you prove yourself, I hope that um, your colleagues will learn to see you as a valuable asset. Very early on in my career, I was working in a hospital. I'd only been a palliative physician for a few months, and I used to go and see people on a surgical ward for this very blunt, seemingly uncaring surgeon who would go on his post-operative ward round and stand at the end of the bed and say to young people, you know, you're an interesting character, but you've got cancer and it'll probably kill you. And then he'd walk off. It was unbelievable. And I thought, I don't know how I'm going to deal with this guy. But he very quickly, when he made a referral to me, he would always put a little passage at the end which said, um, thank you so much for seeing this person. I don't know how we managed before you came because we're not good at this. And I thought, well, as long as people are aware of what they're not good at, then we can go in and help. And I think a lot of the time, when we meet physicians or surgeons who seemingly are full of bravado and sing from their own hymn sheet, I think we can show them that there's a different way. But it sometimes takes years. There isn't a quick fix, I'm afraid.
I think it's also an interesting struggle with patients, though, because we don't get that time of years to establish, to establish that we have that trust.
Yeah,
And I find that that's an interesting, you talked in the article too about how that uncertainty affects patients, but I think it becomes even compounded when patients have been given either certainty or uncertainty in the past that has been wrong. And so
yeah,
then they come in not believing, how many people should have died 5 times before you're talking to
yeah,
them.
yeah,
And they were told for sure they weren't going to survive the hospitalization or whatever it may be. So I think that becomes some of the interesting struggle. And I suspect, that some of that collegial part of it, though, is helpful for establishing you know, our chops. If our colleagues
yeah,
have that confidence in us, they can help us with that as well.
yeah. I mean, I would tell the students, you're actually only as good as your last patient, you know? And and if I go back to that human side of things, of course there are days when you feel like you have to have the cloak on because you're feeling fragile yourself, or something's happened in your own life that makes you less able to open up yourself to their fear or worry or anxiety, whatever it is. But the challenge for us is that we often don't get a second chance. If you're a surgeon and you want to do an operation, if you make a mess of it, you can actually go back and do it again. The trouble with us is that the people that we have are giving us a precious moment of what can be just sometimes a few hours or a few days left for their life. And so that's why palliative medicine is so challenging, because you have to give your all every single time. And
Mhm.
if you can't give your all, maybe you should get somebody else to do it. If you're feeling raw or vulnerable yourself, you can't necessarily always go and give of your best to that patient or the family. Maybe somebody else needs to do that until you can gather yourself and feel okay. Uh, I hope that makes sense.
Yeah, and there's some great comments in the chat too, just about some of the perspectives you've given to some of our trainees on the chat or on the talk and others. So in the interest of being respectful to everybody's time, I think we're going to wrap up. I wish we could chat for a long, long time because this is, and Rod and I had a really great chat. He's got some great insight onto AI and technology and other things that are going on. So I think we could probably chat for hours, but it is Saturday for Rod. So we do want to
Yeah.
let him enjoy his weekend.
Well, the one good thing is that palliative medicine is safe from AI because it it's a human activity.
Mhm.
You can't do it. I mean, you can do some of it with AI, but the thing that people value most is your presence, your open-heartedness, your willingness to share with them. So if there are trainees who are wondering whether or not to choose palliative medicine as a specialty, we won't be taken over by AI. That's
Yes, yeah. Until they can get a soul. Eve commented here that she liked your meeting of the souls. So until we can
right.
give AI a soul, I think we're safe. Well, thank you all for joining us today. Rod, thank you so, so very much. This was
It's
really
been a pleasure.
delightful. I would really encourage everyone. I know everyone doesn't always read the article before this. It's a great article. It's just a really nice summary about uncertainty. And I think it is, as we've talked about here, it really is a very big crux of what we do in palliative medicine. So there's a lot to take away. I highlighted lots of things in this paper. So everybody have a wonderful weekend, and we'll see you all next week.
Thank you
Thanks,
so
Rod.
much. It's been
Bye
lovely
bye.
meeting you all. Bye.